Behavioral Health, operated by and coordinated through the University of Maryland, and funded through a contract with SAMHSA. The topic of our call today is residential treatment programs for children. I think I missed the slide. Here we go. And could I ask if we could do the first poll? Before we get started, we just wanted to ask people if anybody on the call has ever had a child in residential care. Let's just see what we get here. We'll give it a minute. So of those who responded to the poll, let's see, it looks like about 28% have had a child, up to 30, and around 70% have not. So let's go to the next poll. So if you are working with a family-run organization, is your family-run organization or the program that you work in involved with a residential treatment center? Doing such things as providing support groups on site or doing parent-peer support with families who have a child in residential treatment. Oh, we have about, of the 20 respondents, it's actually 50-50. We have a lot more people on the call, so they may not fit in that category, but we do have several people. So we really want you throughout the call, if you are currently working in or partnering with a residential treatment center, please let us know where you are, what program you're working with, and what you're doing with that organization. We want to get that information out there. Okay, so next slide. Okay, so with us today, I am very pleased to introduce Beth Caldwell. Beth is the director of the National Building Bridges Initiative, or BBI, as it is often called. BBI is an initiative dedicated to helping children and families being served in residential programs and their community counterparts to incorporate best practices to achieve positive outcomes. While the concept of systems of care for children started back in the 80s, it was only around 2000 that residential programs were brought into the conversation about systems of care. Previously, residential programs were viewed outside of the system of care, and there was even discussion about whether residential programs should even exist. It was not until around 2006 that residential programs were acknowledged as important components of the system of care, and BBI is a driver in promoting best practices in residential care. It has over 125 residential programs that have agreed to the values and principles of BBI that you'll hear about in Beth's presentation. A major value is family involvement, and Beth Caldwell is passionate about that. I will share that many years ago, my daughter was sent to residential placement for 7 years from age 11 to 18. I will never forget taking Kathy to the out-of-state program, my heart aching, and being told as I took her that it was in Kathy's best interest if I didn't try to contact her for the first 6 weeks, as she needed time to adjust. At the time, I thought this was the right thing to do. Thankfully for all of us, Beth Caldwell has changed that thinking, and it's my pleasure to welcome her to our Family Leaders Learning Community call today. Beth?
Wow, Jane, thank you so much. What a wonderful introduction, and I am so sorry to hear of the that you had there, and I've heard that from so many family members whose children were served many years ago, and hopefully fewer and fewer. And just hello to all of my friends who are on the call, and just so many people out there I've worked with. And really, though, when we want to give credit to the vision and leadership of BBI, we really have to start with Dr. Gary Blau, who was the one who really initiated this and had that vision. So let me first start with just the slide up, which is about some trends to expect around the country, and then we're going to then go from there to BBI. So BBI is really here in our country and at a great time, because as you all can read these 5 bullets here, is there's less money and that we're really focused more and more, the service purchasers, on buying results and not services. And so we're moving from this kind of service intervention to really outcome-driven. And we're also looking, and this is especially true for residential, and you're going to hear some of these themes throughout, is that we're not so focused as much on did the child get better in care. We know there's unlicensed and unregulated programs in some of the western states that actually are engaged in activities that would never be allowed in a program licensed by another state. And they actually have good data, and they find that children get better in care. Children get better in care, the majority of them at some point. But what we know is that does not correlate to a child maintaining those gains once he or she goes home or goes into the community. So we're looking more on longer-term outcomes, 6 months, 12 months, and you'll even see 3 years, 5 years post-discharge. As you all know, because, I mean, what an honor to be talking to all of these family support people and all the great work that you have done. But so we're focused on family-focused services, and we're really focused on permanency for the children and faster moves towards permanency for those children who do not have, when they're entering residential, an identified permanent family. So getting to BBI, we're going to also, I want everybody to kind of put their seatbelts on, because I had asked Jane if we could have 4 hours for this webinar, and she said no, we could only have this hour and a half. So we're going to go fairly fast through some of these slides. But I know that the PowerPoint is available to you, and so you can print it out, and tonight when you call a friend, you can read it to your friend, or when you get in bed with your significant other, you can read it together, so you can really get all the words that you need. So this is BBI's mission, and really what we want to share is that Building Bridges is a national initiative, as Jane shared, to promote positive outcomes for youth and families touched by residential interventions and their community counterparts. Language matters, as families know. And so we're moving away from residential placement or residential treatment, even if it's licensed and using that language in different state documents. We're really wanting to move towards residential interventions, that it's a short-term intervention. BBI is not a model. It's not a model of care. It's a framework, and it's a foundation. And when one wants to ask why, or how did it come about, Gary tells a very long, wonderful story about that. But for today, we'll say that there hasn't been outcome data done on residential children who are been touched by residential interventions in the past. And there's been very little, I should say. And the one seminal study done found that 75% of the youth who received residential treatment services were in prison or a psychiatric hospital 7 years post-discharge. So we know that residential is one of the most expensive services there is. It's the second most expensive after hospitalization, and it has the least outcome data. But that's changing. We also know that there's no evidence base for residential. So there's not an evidence-based residential model that you can say, oh, let's use this. There's no evidence base yet for residential. But we also know, as Jane shared, we're going to need out-of-home care. There's places like L.A. County, Los Angeles County in California, where the wonderful Michael Russo has led an initiative to really reduce residential, and in fact, he has a particular focus on reducing residential for children under 13, because we do know now that the more placements, I use that word with quotations, but the more different residential programs a youth is in, the more likely he or she is going to be in additional residential programs and not move towards permanency. So trying to really focus on those children under 12, under 13 is extremely important. But we know we're going to need residential still. We're not at that place across the country. And even in Wraparound Milwaukee, which we know has been doing wonderful system of care work for many years, and they've reduced residential significantly, that we still have residential there, and we're moving more towards a best practice framework. So really, BBI is changing the paradigm from a focus that used to be solely on youth getting better in care to really about supporting the families and the youth with the skills and supports they're going to need to be successful when that child goes home, goes back to the community. As you see in our mission statement, it's all about partnerships and collaborations, first with families and youth, and also, as you'll see, with all of the family support and youth mentors who are out there. And it's, again, focused on sustained positive outcomes, because we always seem to, even today, residential programs sometimes get stuck and start focusing on what they can do in the program versus really thinking for the long term. Please go to our website if you have not yet endorsed our joint resolution, which was written largely by families and youth. And I see Pat Hunt's on the line from Magellan, and she was there at the first BBI summit when we actually developed this. All you have to do is email Gary or myself, and basically you're going to be on a listserv, but it's a wonderful listserv because you're not going to be receiving tons of emails. Maybe you'll get 5, 6 emails a year, and each time you get an email, what's going to happen is that you're actually going to get a new BBI document with it or be invited to a BBI event. Like I said, we had a very successful training event in 2005. I see a number of you who are here on the line today. We're at that event, and we're going to be having another event in 2007. So you will be invited to that. So the one thing I want to say about the joint resolution, and it's really almost like reading a system of care document, is the families and youth included in there a commitment to strive to eliminate coercion and coercive intervention, and that includes things like restraints and seclusion, frequent police calls. It's really preventing, helping youth to self-regulate. And what we find across the country is that when residential programs have not really addressed this, when they still have high rates of restraint, seclusion, AWOLs, police calls, aggression happening, they're not going to really be able to get to the important practices that result in sustained positive outcomes. So many times states who want to endorse and work with BBI first focus on making sure that they've given the programs the tools to really help youth to self-regulate and promote youth voice and choice and trauma-informed care. So these are our BBI core principles, and as you all know, that they're the same, very similar to what you'll find in a system of care principle list. Family-driven and youth-guided are our most important ones, the ones we've done the most work with, and then we've started and have done over the last, 5 or 6 years, we've done even quite a bit of work in cultural and linguistic competence also. And all of these we've done some focus on, but again, family-driven, youth-guided has guided most of our work. So some of the critical issues related to residential effectiveness. In one state in 2009, they tracked every youth who was discharged from residential that year. And what they found that 68% of those children were back in out-of-home care within 1 year of leaving residential. Whereas DAMAR services in Indiana, which we'll have a couple slides about them later here too, is that they have a 3 to 11%. I actually have to change that. It's gone up to 15%, and they're looking into that. So when you think about you being a family support provider, what type of residential programs do you want in your geographical area? Ones that are going to have the least readmissions or ones that are going to have their very high rates of readmission? The other piece that we know is length of stay matters. And many of you are very familiar with John Lyons and his work. What he's finding is that after 6 months, that residential efficacy or the potential for residential efficacy goes down. New York State actually did a study, and they found that after 9 months in their residential treatment centers, and some of you are from New York State on the line are going to remember this with David Woodlock, and they actually found that children got worse after 9 months. So, but what New York State did about 12 years ago, they found that their lengths of stay were quite high, maybe 24. Any of the New York State people who want to add to this, you can chime in. 24, 26 months, 22 months. And so they hired these transitional coordinators, multiple ones for different, what they call residential treatment facilities, but they placed the transitional coordinators who were supposed to help and support the families and the youth in transitioning back to the community from day one of admission. They placed them in the residential programs. So what happened is that when you're placed in a particular culture of care, you get subsumed into that culture. So you would find transitional coordinators spending all their time calling family members, or you would on the phone rather than going and spending time with them in the community. You'd find them leading discharge support groups versus individually working with the youth and the families on what discharge needs were happening. Florida actually did a very similar thing. They had a high average length of stay. They wanted to reduce it, and they were able to reduce it, as it shows here, in 3 years, under 6 months, because they put their clinical transitional coordinators in the community, where their only focus is really working with the youth and family and all of the community supports, including family support groups, in moving that youth and family to a place of safety and success in the community. I wanted to share this from KVC in Kansas. KVC is actually one of the few child welfare privatized child welfare. Kansas has privatized child welfare, and KVC runs that. But they also operate an RTC, Residential Treatment Center, and their Residential Treatment Center has a 2-month length of stay. They actually believe that they're going to be able to, over time, not even have residential because of their ability to work with families and work with foster parents and giving them all the same training and supports that they give their own staff. But if you look at many, they really came from the heart, which is that, like all of us, children need to be with families. And so this kind of just summarizes some of the research about the difficulties of congregate care and why we really have to work to, as Jeremy Caholbrand says, who runs Children's Village in New York State, is that residential should be like an emergency room. You get children in and you get them out, and that's where we do most of the work. So here's contact information after each of these slides when I mention somebody or mention a state. So if you want to really find out about residential, just read this article. We encourage you to read our book, which we'll mention in a minute, but this really summarizes the research on residential. We already talked about shorter lengths of stay, and the most important is family, family, family. And each of you on the phone have positions where you're dedicated to family. So in many ways, if we could connect family support groups with every residential program in the country, we would significantly increase family involvement. And it could really increase positive outcomes for the youth and families we serve. And then, of course, stability and support in the post-residential environment, which is also a critical, and many residential programs do not provide that and just hand children off. And because that's how residential has been contracted. And so we really have to put a lot of energy and effort into supporting people building this post-residential environment from day one of admission. So here's some examples of where BBI residential transformation work has been or is happening. As I said, Pat Hunt's on the phone. Magellan's been a great partner for BBI. They've done work in Virginia. They've done work in Louisiana. They've done work in Arizona, really supporting best practices and positive outcomes in residential. So there's a number of actually BBIs involved with the Annie Casey Foundation, and we are expanding into 4 new geographical areas. So anybody's willing to email us and say, gee, we have a geographical area, we would like some support. And the support would come from BBI, paid for by Annie E. Casey. So let me know if you have a geographical area that you need some support. So Massachusetts was the first state in the country who decided to rebid every residential program that was licensed by behavioral health and licensed by child welfare, which included some juvenile justice, against the Building Bridges principles and practices. And what they also did is they significantly expanded the number of family and youth partners, parent partners, and peer mentors to the tune of almost 300 they hired, and they housed those people in the community family support agencies throughout the state. And so what happens is these parent partners and peer mentors are likely already working with the youth and family prior to the decision to have residential, and then when they have it's decided they need the residential, that they actually work with the families and youth throughout residential and post-residential. So Massachusetts has developed that kind of a family peer partner and youth peer mentor framework, and they've been very happy with that because it addresses, all of the areas that from the research of what's necessary. They've done a lot of other work in Massachusetts, but I just wanted to really point that out. Here's an example. We're going to get to another important area. Plummer Home for Boys. I don't know if anybody has known James Lister, wonderful man. He's the CEO of Plummer Home, and when he took over at in 2009, it was like he was like all excited, and he got money, the board to give him money to clean the place up and get new furniture and do new best practice training for the clinicians to do work with the youth inside the program and group therapies and individual therapies. But they started tracking outcome data and found out that all of that didn't translate to better outcomes for youth. So they actually, it's not even a proposed anymore. They changed their vision statement. And what they found that better programming did not equal better outcomes, that the primary focus for every single youth has to be on family, on permanency. They implement Family Search and Engage, do extensive parent support and education, and building community support networks. Mark Nichols from Chapin Hall, the University of Chicago, who's done so much research with our youth, the youth who we serve in the child welfare system and their families, he's found that the community support network that a youth has at discharge determines outcomes 10 to 15 years later. That's how important. And look what Plummer Home for Boys does. This is what they focus on. So here's contact information for them. California, as many of you know, is one of the first programs, first states that really started a focus on retooling residential. I like how they talk about it in Los Angeles County, and RBS is their residential-based services project. They started with 4 different pilots in 4 different parts of California. They have really helped inform BBI, and they've helped inform best practices for residential across the country. In fact, their residential-based services projects in those 4 pilots was so successful that they actually got it in legislation last year that was approved to go statewide. But look at what this slide talks about. We're talking about transforming this focus of residential facilities from long-term placements to short-term, family-driven, open therapeutic communities. They're not place-based. We have this seamless transition to and from the residential. And I also want to point out is that these are some of the critical components of their program practices. And what I've highlighted is like a wraparound. All of you are familiar with wraparound. Some of the programs use wraparound to Fidelity. Some of them have to use an adapted wraparound because of funding challenges. But they have a framework where there's a family support person supporting that family in every treatment team meeting. They, from day one, the first thing they do, even if you have an identified family member, they expand. They focus on family search, engagement, preparation, and support from day one because we know it takes a village. And almost all of you, if not all of you, have had children, and I know some of you, and the struggles you've had over the years with your own children with behavioral and emotional challenges. And so they're talking from day one, if you don't have an identified family, we're going to find identified family, and if you have identified family, we're going to work with you to expand the support network, not only in the family, but building those lifelong connections. So these are just some of, when you're thinking about residential, my goal today is for you to immediately start thinking about it in terms of what are best practices in residential now. So when you look at all the residential programs in your geographical areas, you're beginning to weigh them against these practices. So Hathaway Sycamore started with Wraparound to Fidelity. I'm actually not sure if they are still doing to Fidelity, but that's like a primary practice of their residential program. And what they had at one point is 44 family advocates. I mean, nobody did anything there without family or family advocates involved. So that's, for you all, family support organizations, when you have family advocates in residential programs and community programs, how wonderful, because then it's easier to support them. So Mark Nichols at Seneca Family of Services in California also. And when they started their residential transformation, they started talking about who their loneliest child was. And their loneliest children were children from child welfare who had no identified family. And so what their practice model is their practice model for residential is actually family finding and wraparound. That's the practice model. That's the most important thing they do. They sometimes have youth referred to residential and to their highest even level of residential, and they're called group homes, and they have different numbers in California. Those of you out there know this, and to delineate the highest structured residential programs. But anyway, they sometimes have children who come in to residential, and they're able to, within 4 days, 2 weeks, 3 weeks, they're able to actually put the child back with the family, because their family advocates are so sophisticated and they are so focused on wraparound and getting into the community that they can see, wait, this family has strengths, so many strengths, that we can wrap these services around and have such a very short residential time. So once again, they focus on urgency, family finding, and wraparound process, and they're actually moving to every a residential framework where they're looking at 30, 60, and 90-day programs. That's their goal. So here's information on the California Reform Initiative, if you want that, including some of their outcome studies and information on contact information. New York, just to say a couple of things about one program. I've already mentioned Jeremy Cahobran, who runs Children's Village, and as one of the first things he did was to hire these parent advocates who are, all of them are connected to New York State family support organizations. So each family whose child is in residential, they are supported by family advocates, and those family advocates are tying them into these New York State family support organizations across the country. And they have family advocates who speak multiple languages and really represent the culture and the diversity of the youth and the families served. So as you see, they've developed a number of very short-term programs. They actually had a board member, Jeremy's really great at this, because they realized that they needed follow-up and support, so they actually had a board member provide 1 year of follow-up for every single youth served in residential. They could call it their flex funds. So basically what they found, because what we're finding is so important in residential, is that one of the first slides I showed you is to look at outcome data. And what they found is that 75 to 80% of all of their aftercare flex resources were going to the families with the highest need, 15% of the families. So they actually implemented evidence-based MST, and you can see here from one of their first studies, and they've had multiple studies after that with even better results, is that when MST is wrapped around residential for very high-need families, look at the success rate. So we're wanting people to use data to inform practice and then use interventions that can really support improving outcomes. So Indiana, I mentioned DAMAR. They're up to date. They don't have the 2016 data yet, but this is their long-term outcome data. So this is looking at, they call it recidivism. BBI likes to call it readmission. And their actual definition of recidivism includes even children who, after discharge, 1 year, 2 years, 3 years, has a hospitalization, that's counted as recidivism for them. So they do it 5 years post-discharge now. And again, here's their definition of recidivism, that the youth is not placed in a similar or higher level of care. And this is, all of you know as family support people about incident reports, and every residential has a ton of different incident reports. And what DAMAR has found is their most important incident outside of something like, a near death or like a huge safety issue is that if 24 hours goes by, this is a residential program, and a youth is not spending time with his or her family or spending time, say, in the Boy Scouts or in the church choir or something in his or her community that matches what they're going to be doing when they go back to their community, it's considered a critical incident, and a plan of action must be submitted immediately to the COO. And phone calls don't count with families. So what they have done is looked at their data, and they found that the more time that youth is spending with family, the better long-term outcomes they have. In fact, Boys Town in Nebraska has done recently released a research paper they did that found very similar. It's the spending time with family and spending time with family in their home and community. So Daymar actually changed their whole business model. They happen to have a fantastic leader, so their business model they didn't go fall apart. They actually improved with their business model in terms of finances. But their business model is now they do not serve children and families who are, and I don't remember if it's 45 minutes or 45 miles away from their program. So I know many of your residential programs across the country and your geographical areas are not able to do that, but we can get better at that, and we can really, family support organizations are the best people to support state and county state agencies, oversight agencies with making changes, and one of them, most important, is geographical areas. So I love what Jim Daulton, the CEO, talks about. This is his language here. We used to actually think that a child was sent to residential, and then their residential was going to make them all better. That was their job. They're going to make them all better. And many times the families are so exhausted, they just want to leave them there because they've had such a challenging time with no support. But with all of you across the country leading family support organizations, that's not as much, we hope. But our job in residential is not to cure kids, but it's really to support the youth and the family, negotiate the basic task of everyday living. So when they say residential treatment, we're not really so focused, as I said in the very beginning, about removing problems. As you know, your own children, many of you have had behavioral and emotional challenges. They don't go away overnight, and many of our children are going to have to address these things for the rest of their lives. And so what they do is they establish conditions that allow that child and family to manage symptoms at home more effectively. So I love what he said. And what they did, because their funders would not fund a different way of doing business. Jim Daulton came, some of you, well, Pat, I know, was at the first summit, and when he heard family and youth speak and heard their voices about the challenges and how hard it was for them, with a similar story, Jane, to what you shared at the beginning and others, he said he went back and said, I have to change things, but he couldn't get funding to change things. So he made a commitment to his oversight agency. If a youth required readmission post-discharge, Daymar would do it for free. And, well, what if we all began to guarantee those outcomes? He said it totally changed the way they did business. So what's the role of family within their organization? They're considered the co-expert. They employ family members. They are part of training. They're part of interviewing every staff. They're on their board. They have family advocates as well as family members who are just employees. They're part of their quality improvement, and they work as liaisons back to the community. So it's a huge role for family when you think about getting to 3 to 15% readmin after 5 years. So other steps is I could stay on and give you, so many wonderful stories, but, people are doing all kinds of things to improve practice in residential and thus improve outcomes. They're using the documents that are all over our website. Please go to our website. You'll see so many documents. www.buildingbridges4youth.org. You'll also should order our book. We do not get any money. Gary, as a federal employee, is not able to. And the other two editors, myself and Bob Lieberman, actually donate our money. I actually donate my money to Youth Move, the royalties I receive. And so think about ordering our book. Jane, or you can email me or Jane about that book because it really helps programs. Lots of programs actually have groups of staff read all the different chapters or read some of the documents on our website. So lots of things you could do: rewrite regulations, licensing based on BBI principles, develop teams. And as Buckminster Fuller says, we're not talking about just, okay, a few different small improvements to residential. We're really talking about transformation. We're talking a whole different way of doing business if we're going to change the trajectory of the children and families who we're serving, and if we're going to really focus on achieving sustained positive outcomes post-discharge. How are system of care communities, and state and county agencies and city agencies? You can implement family finding, family search and engage. You can do family team conferencing through Wraparound to Fidelity. There's lots of different things. We have to try to get more flexible fiscal policy and practice models, and also increase, as you already know, these community programs and supports and training and supervision. Supervision is so very important. I have seen family advocates working in residential programs. I went to one, it was like in January, and this was upstate New York, and this particular agency not only ran a residential program, but they also ran a MST, multisystemic therapy. And so I was talking to a family advocate, and she says, I don't travel between December and April. And I was like, why not? She goes, well, because there could be snow. And so I just talked to the families on the phone. It's like, who's supervising that? The MST therapists are out there meeting with families in the communities. So who's supervising that? Another family advocate who actually worked for a family support organization, but then was, focused on a particular 3 residential programs, that when I interviewed her, she said, we used to have a lot of really good families, but now we have a lot of dysfunctional families. And I was like, this was the family advocate that worked for the family support program, but it's like there wasn't supervision. And so it's really important, and that's what could be so wonderful about family support programs, is to really, really keep the bar very high about expectations for family advocates, and really not having family advocates be subsumed by the culture of the residential program, but helping the family advocate to improve the culture of that program. So what other things we can do is we need family youth advocates in every community, and we need family youth support services in every community. So you all know that. This is something that really can support residential when we're connected. So these are some other pieces here that you can focus on. We not only want state agencies, oversight agencies, to focus on building bridges principles and best practices, which, the family-driven, youth-guided, but really supporting the programs on how they move from control to collaboration, and remembering that it's not just trauma-informed. And so for many of you, you probably have heard like, oh, my goodness, our program is using Sanctuary model, a residential program. With Sanctuary, I love Sandra Bloom. She's the grandmother of trauma-informed care. But Sanctuary has no outcome data. It's evidence-based in residential that the child's going to get better in care. And as we know, as I said, unlicensed, unregulated programs do very well with kids getting better in care. But there's no outcome data that children do well once they get back to their community. So sometimes residential programs have to make some really hard decisions. I've been in a couple of triple certified, meaning, they've been 3 times certified in a particular practice model. So it could be Sanctuary, but yet they have a very high rate of staff turnover. They have a number of youth who every year they send to jail because the youth got aggressive. They didn't reduce restraints. We're looking at trauma-informed that's really about promoting youth voice and choice, and really that we're looking at whatever practice we have, that it is achieving certain outcomes. So even TFCBT, trauma-focused cognitive behavior therapy, fabulous model, is evidenced in the community with the family and youth. So residential programs that have not become family-driven and aren't yet successful in successfully engaging families will say, we'll appoint a staff to go with the youth to the TFCBT meetings because the child won't, because the parents didn't show up. Well, basically what, say, Beckett Family of Services did, who runs a residential program in New Hampshire, is they do TFCBT, but they do it in the family's homes. So just really watching out when we say trauma-informed care, we say evidence-based. There's no evidence in residential, but are they using those evidence-based to the criteria, which is where the evidence came from? So moving on, these are some consistent challenges faced, and many of you already know this, is that most state agency documents and regulatory oversight does not include best practice expectations. Massachusetts redid everything they have, from their licensing to their Medicaid to their contracts. Delaware on the mental health side did the same thing, to put in best practice expectations. I know Pat Hunt and Magellan have started that in Louisiana. They're doing that in Virginia. So they're really moving, because basically many of the practices that are currently within the state agency oversight documents are not only not best practices, but they're actually contraindicated for effective outcomes. So we have one state that allows 0 overnights of the child when he or she is in residential to go spend the night at home. They will not, Medicaid will not reimburse for even one night at home in that state to the residential program. Whereas other states, like New York, they have 75 days a year the child can spend at home and overnight and still get reimbursed for it. So we need to make those changes. Many states who have begun to transform found out, wow, they didn't include probation officers or child welfare workers in the training and the understanding of best practices, and so they actually hurt us, hurt the movement, because the probation officer will say, he's not going home this weekend, he didn't go to school. So they're not really understanding that, in 3 months when he leaves, the family's going to have to deal with him when he doesn't go to school. So, and then many residential programs, not because they're bad, we need residential. We have wonderful people who work harder than any other program I've ever seen is in residential, but they haven't yet been exposed enough. As many of you remember Joanne Hust, who was very involved with BBI in the beginning, and she says, we trained, they learned this about families, and they can relearn about how to engage families. So these are just some things that we want to support. So I want to say, even though all of you know everything about family-driven care, here's a few studies that you probably already read. I just want to emphasize that the most important thing we can do with the residential programs in your geographical areas is to support them on their journey to successfully engage families and to move towards family-driven care. And what we find again and again is the most important thing is hiring the family partners or advocates. And that we have different models. As you saw in Massachusetts, the family partners work in the family support organizations, whereas in some other residential programs, they actually work for the residential programs, say like Children's Village, and they connect to the family support organizations. But we want multiple family partners and advocates in every residential program or connected to every residential program. We want them to have, as you all know, nothing about us without us, that there shouldn't be anybody hired without family members and youth being part of that there shouldn't be any training that family members are either not co-training, and as they do at KVC, every single training offered, and I mentioned this before, to staff is also offered to families. So some of these same, and they're part of evaluations for even the psychiatrist, that you have family and youth, and this one's about family. So these are just some of the examples of family-driven care that you would find as you're going into the residential programs in your geographical areas. Does their mission and value emphasize family engagement, working with families, or all about youth? If it is, then they need, we need to support them in improving that. What about their commitment and orientation and training and supervision to family-driven care? Do they have sibling support? When Massachusetts was moving to transform, we interviewed, and it was such a treat to be on that team, interviewed over 300 family members whose children were currently in residential at the time. And the second most identified need was sibling support. As you all know this, I'm speaking to the choir. So clinical expertise, the only real models out there that include evidence-based and best practices on how to engage families are multisystemic therapy, functional family therapy, wraparound to Fidelity, and actually also motivational interviewing. We need to give the clinical staff these types of skills. And so these are just some of the areas, but do you hear your program saying home visits or home passes and kids have to earn those? Those are absolute no-no. Spending time at home is one of the most important practices with staff at the homes. And so what you find when staff start taking their first steps, or programs taking their first steps on this journey, they want to have meetings in the programs. They want to bring the families in for these types of events. Your own in New York State, Karen Ann Johnson, who works for SCO Family Services in New York City, is what they do is they have their family support groups of families in the residential program in the different communities where the families live. Because we all know that one of the things you want most for your children who have behavioral emotional challenges, or for any of our children, is for those children to heal and to increase their self-esteem. And when they are in a program that is using something like points or level systems or any of the other kinds, which are totally contraindicated for promoting youth voice and choice and trauma-informed care, and then they're having to also experience and hear, and I've heard this, and many of you have heard this, that the program, is going to have this big family dinner, and then their parent doesn't show up, and they hear the staff talking about, she doesn't show up again, she doesn't care about him or her. And we all know that the reason they didn't show up isn't because they didn't care. There's too many other challenges. And so really working to say that family-driven care practices are things that we do when the family wants them and where the family wants. Even things like holidays. How many of the residential programs are still celebrating holidays in the residential program with residential and staff? And then their next step is to celebrate it with the families. But, of course, some of the families don't show up, so we hurt that self-esteem of those youth whose family members were not able to do it. So really thinking about how can we build memories for families versus how can we build memories for staff, so that there should be no more of this taking kids to Six Flags over Texas. If we get tickets to Six Flags over Texas or Six Flags over Mid-America or any amusement park, we invite families and the staff go with them, and maybe the family advocates, that the families are the ones they're building memories with. And as I remember in New Zealand, there was this hospital. As you walked in this hospital, there was this absolutely really good-looking young woman. And a lot of you don't know me, but I'm a very good-looking young woman, too. So anyway, so there's this beautiful young woman with this beautiful smile who welcomes you into this hospital and just makes you feel good just walking in. And when you look at her job title that's on one of those little things on the desk, she's the Director of First Impressions. And as the National Council for Behavioral Health did a study, is they found out that the first impression a family has is going to determine outcomes by like 78% or something. So what you want to look for in all the residential programs in your geographical area is that every staff member is this Director of First Impressions, that youth can call families, not just their moms and their dads, but their grandmas, their cousins, their siblings, their aunts, their godparents, and they can call them frequently. In fact, they're moving towards, in many programs, giving the youth their cell phones with the, turn off the photos and things. So these are just a few examples. We have so many other examples, and I know that many of you are well aware of this. I see names here of people who are just so advanced in BBI. So what to be cautious of, we've already talked about residential campus, events on campuses, lack of sophisticated committed clinical supervisors, and group residential recreation. We talked about making sure we build memories with families. But what we also want to do when we're really talking about family-driven youth-guided care is that when a youth comes in to their residential, or even before, we're identifying with his family member, with his siblings. Not Ross Green, but Glenn Sachs does with trauma systems therapy. They even, get neighbors involved maybe, or coaches. And what does this youth love to do? And really finding out from him and his extended support system, and connecting him or her to recreational activities in his or her home community. So now the rec therapists are working with the families and the youth in their home community and transporting those youth to stay engaged in those activities, because the longer they're away from their community, the harder it's going to be to get back in there and feel supported. So we're moving away from group recreation and moving away from these holiday traditions at the residential. I actually challenged the whole state of Massachusetts that in 2016, so this was in 2015, that every youth in every residential program spend every holiday with their family member, with a family member, that they would make that happen. And so really thinking about in your own residential programs you're connected to, are these things changed, or what can you support? So with that, in terms of family-run organizations, here are some priorities. Reach out and develop partnerships with every program in your service area. Move to best practices. As we already said, give them the BBI website and the documents and tell them about the training event that's going to come up in 2017. Get them on the listserv. Offer family-driven care orientation and encourage hiring of family advocates. St. Mary's of Rhode Island, who has really transformed in the last year, they reached out to their family support organization, and they have partnered in the most wonderful way to really transform their residential. And they literally, it's almost like the CEO doesn't go anywhere without the family partner who is working for the family-run organization. So there's so much can be done, and what I wanted to do is open this up for questions and discussions. I know, Jane, you might want to talk about, or maybe you're going to get to that later, that BBI on our website has, and we developed this at the very beginning, maybe 10 years ago, a family tip sheet. It's available in Spanish, too, and we have a long and a short version, but it's a tip sheet to give to families about residential. But it's old, and so Jane has offered Fredla to actually update that tip sheet and make it more specific to some of the practices that have been identified in the last few years. So I rushed through that and didn't even share many of the stories I would have loved to have shared, but I think what we should do, Jane, is I think we should open it up to all of these wonderful family support leads and see if they have questions and comments. I haven't been able to read the public chat, so I don't know if anybody put a question in the public chat. So I don't know if anybody wants to help me and determine that.
Yeah, I'll check on that for you. But back to your tip sheet. So Fredla will be working with BBI to develop a tip sheet for families caring for a child that may be in residential care. BBI has an incredible family advisory work group, has from the get-go, and we will, of course, be working with them, but we invite you to join us on this. So if you would like to be involved, please email Melissa Pearson, and we will put together our work group to develop or revise the tip sheet for families. So I want to open it up. Let's see. We have, let's see, tips for helping families providers who feel the opposite and think residential is the answer. Any advice for helping families? I know myself, when I worked in the family-run organization in a state, we had so many families coming in the door, help me get my child into residential. So how would you guide a family?
Right, and so I think that that's a great question, and I know in some of the training, and Nancy Craig might remember this, or Pat, that we did in New York State. There was this fabulous leader of a residential program, and he began to actually just start developing almost like bullet points for staff to use with family members. And so because that first, again, the director of first impression, that first engagement counts. But immediately, like one of the first things they say to the family member is, I know you love your child and want the best for him or her. They get to the empathy. It must have been hard to make this choice. It must be hard. You must be exhausted. And since I know you want the best, and he did it brilliantly, but he had these like cheat sheets for his staff in those first encounters with families, is that the evidence is very clear that the most important thing we can do is to work together. People used to think that residential was to fix the child, but now we know that even if we fix the child, that it doesn't mean that he or she is going to be successful at home, that residential is an intervention that's for families and youth. And if you're tired and exhausted, we're going to support you. But we really are going to be working together from the very beginning. And so, you create these ways to let families know. And in fact, this guy, I saw him once in reality when he was meeting with a father and a stepmother, and both the father and stepmother, the first meeting was like, I'm not doing anything with this child, and the stepmother said, I don't even want to see the child again, that, he's going to residential, this is it. By the end of the meeting, the father had agreed to be part of some work group with families, and the stepmother was looking forward to welcoming the staff for dinner when the child came back like 3 days later to be at home. He was just like, I say, clinical supervision that promotes this. I've seen so many clinicians in residential go to the clinical supervisor and say, look what this family did now. And the clinical supervisor will roll his or her eyes and say, yeah, I know. You can't really work with families like that. That's not what happens with MST or FFT. What happens is the clinical supervisor is saying, oh, wow, let's look at what we can do to engage this family. What should we have done differently? There's a whole culture of what you all have as family support people. You have that culture, and you have to support clinicians in doing that from step one. And with those families, what they call is, in Chinese, what is it? Nancy knows this. It's like crisis is an opportunity, is the same word, is that when they first are referred or come to residential, that's when we start talking about, we don't only need you, who else in your family loves this child? We need them involved too. We need to, if you're exhausted or if there's things, we need to set up respite for you. You're as important. Your needs are as important. So Warwick House in Pennsylvania, Magellan sponsored a fabulous program in Pennsylvania with, like I say, the Northeast Quadrant or Southwest, one of the quadrants of Pennsylvania, and they partnered with the residential programs, have tremendous outcomes. You can Google or email Pat Hunt about some of the papers they've done. And so what Warwick House has done, and it's saved the state money, is that they have a very short-term program model, and they have, for every 5 families, they have a clinical staff that works with the child and family, and then they have a care support person for the family. So you have a family member who's in prison, but he's going to get out in the next year. Or you have a family member who is constantly going in and out of a rehab. So they're setting up support mechanisms. So it's really about the family. I hope that wasn't too long-winded.
No, you're right on target. I just need to make a couple comments for people who have said that they're not on the webinar. How can they get the slides? They will be available in using other methods. Fredla will also make sure that it's emailed out broadly, and it's also going to be on the Institute's the University of Maryland Institute, and in about a week the recording will be available. So all of these materials, and there's also resource documents that Beth has provided that will also, they're here to be downloaded, and the university just said that the classroom will be open following this webinar for a while so people can still download the documents if they want. And of course, as I say, we'll get all of this out to everybody. It's been such an incredibly rich conversation, Beth. So I
also see, I want to say Barbara Granger from Texas, like BBI's doing a big event there in Austin on January 4th, I believe, and we have a big event with Virginia and Magellan on December 8th, if somebody's from Virginia. So, yes, get involved. BBI traditionally, because we are working today with you, Jane, as kind of the co-presenter, is that, as Nancy Craig knows, as Pam knows, we always have family and youth as part of our presentations. That's Pam Brandman, who's also from New York. So, yes, please get involved.
So a couple of questions come to mind, and somebody brought this up about, in many parts, the geography is a major challenge in terms of visiting their children, or even the staff being able to come into the home. How have programs dealt with that? That's not an unusual situation.
Excellent question. I just want to do a call out to Mickey Toker, too. So geography, this is where we need you. Family support organizations are, they're such great lobbyists. I guess we're not supposed to say that word, but advocates. And we need to change the focus of just putting children anywhere and try to have them close to families. And so one of the things that often happens is that a residential program, and Barbara, I know a couple of your programs in Texas, they were able to look at their children and say, oh my goodness, like there is a whole group of our families who do live within 50 minutes or an hour of here. And so what they did is they did some first steps where they're actually were going to work with those families first. They couldn't work with all the families because some were 8 hours away, Texas, but they could work with those families. What one program did, and this was a program that actually they got exposed to BVI through Magellan in Arizona, Maricopa County, is that they decided on their own, just like Jeremy Coburn did with Children's Village, is that they would pay their own money for a year to have clinical staff working with the families, and they would present that data. And some of those families were a couple hours away. They would present their data, and they did, to Magellan, and Magellan funded them the second year for that service. Up in New Hampshire, they just made a commitment. Again, this Sue Beck, she just made a commitment. Every youth was going to get home a minimum of once a week. And in New Hampshire, you got 3 and 4 hours away. And she really got a lot of grief from her CFO, Chief Financial Officer. You're spending so much money on gas. You're spending so much money on gas. And she goes, yes, but, staff like it better. We're having less incidents with kids, so we're saving money in so many other arenas. And they got every child home. And their goal was to do it twice a week, but they were able to get and they drive those hours. And what they did is they hired staff. Every residential program I've ever been connected to, and I'm going to be in the Guinness Book of World Records for going to the most residential programs across the state. I've worked with programs in all 50 states. Is that they have what they called unfilled, in the staffing human resources, unfilled positions, and they kind of can save money with their unfilled positions. So what this program does is that they hire former staff who have the mission and values of this organization, who maybe became a mom and was going to stay home for a little bit but still wants a little bit of work, or went to graduate school and still wants a little bit of work, and they hire those people, to do a lot of the driving. So there's wherever there's a will, there's a way. But at the same time, you want to work as much as possible with the state agency in changing that so the majority of families and youth are able to live within an hour, hour and a half, ideally 45 minutes of the program. So there's many answers to that, and it depends on the program. And I don't know if any of the New York State people want to talk, because I know, like up in the Hudson River region, way up north, they have programs that, whose children, they're 4 hours away, and they regularly get those kids home because they do deals with the family, like we'll meet you halfway, or we'll pay your gas halfway. They just are creative in making it happen. And again, it's not just the youth getting home, but it's the staff working with the families with the real problems that happen. Because the problems, if you go into residential, you're going to see a lot of the problem behaviors they're working on actually aren't the problems that are happening with the family and the community. They become problems because of residential. So I hope that helped. It's not a total answer, but if you want to discuss it more, anybody could email me. And I could connect you to programs that have made it happen.
Another question is funding around family support. And I think you answered part of it. Where there's a will, there's a way, if the residential treatment center wants to do that. But oftentimes, families have private insurance, and they're going to private practitioners. And I know many private practitioners, not that they aren't, many of them wonderful, but many are also the ones promoting residential treatment. So how, we would get calls from families. My psychiatrist says the only thing to do is to put Johnny in residential. How much work, if anything, is BVI doing with, the Academy of Psychiatry or social work or whatever to be able to, I should say, open their eyes to all of the rich data that you have showing that residential is not the answer long term.
Right, for long term. Well, most of those private insurers aren't keeping children very long anyway, from what I understand.
Yeah.
But I wanted to go back just real quick to the geographical, just because I want to say one other thing, is that what some programs have done is they've decided, okay, we're going to have this apartment on campus where families can come and see this child. And now I know sometimes with child welfare or juvenile justice that actually has to be an answer, but it's not the answer, and that would be the last thing we'd want people to spend their money on, is to build an apartment on a residential campus. Because then you're going to, and I've been in those apartments, and I've been there when families were there, and it takes massive amount of oversight because then the families are kind of lost when they're there. So I just wanted to throw that out about geographical. That's not the answer. But in terms of the funding, we do have one fiscal guide on our website available. We're finishing up, we hope, by early 2017, March 2017, our hope is, another fiscal guide which will give some examples, and I don't really remember if this particular issue is there. I'm asking Kelly Pipkins-Burt, who is our new BBI lead consultant, if she'd write that down so we can follow up specifically with the private insurers, making sure that we do address that in our upcoming, or address it somewhere. So, one of the first things Massachusetts did was actually have some training for their managed care company about best practices in residential, to have them understand it. And so I would think that a similar piece would be to give people, if the family support organization is providing families with advocates when they're meeting with potential programs, or is to really advocate for best practices. So I'm kind of fumbling really, because I don't have a specific answer for the private insurance, but I do know go ahead.
I'm sorry. Well, it often got to the point of families relinquishing custody to get residential treatment. They felt that their psychiatrist was telling them this is, and we know that families will go to any length to help their kids. And so it got, the only recourse, if insurance wasn't covering it, was to go to social services and relinquish custody.
Right. Now that's the whole area for states who still have that archaic practice to focus.
Yeah.
So that's that's definitely an area that is changing the state. And that there's so many states states who have done that successfully. So that's something we should all be working on, actually.
Yeah,
if it's not,
absolutely.
if it's happening in your state. But I'm going to have to, try to respond back to you for you to share, Jane, about this issue with private insurance. I don't remember, as I said, what's in our current guide or the one that's being written. And I do feel that some of it is just, we're finishing a guide right now on short-term residential that will be out in mid-March too, and we're finishing a guide on working with judges, our judges guide for best practices. So we're trying to hit different different people who are involved in that residential decision-making and what are best practices, and we can definitely put that, private insurance and what we can do to support that in the future. So if we don't have an answer for you, we'll definitely put that on our list of things to focus on.
In reading your book, and I highly recommend that everybody get a copy of the book, it's very easy to read, very readable. Gary and Beth, co-authors, along with, I think, is it
Bob
Lieberman? Bob,
editor.
Yeah. And one of the things that struck me was it seemed, and I could be wrong on this percentage, almost 50% of the kids were in residential due to education. our education systems placing a lot of kids. And
yes. And I don't have the exact data in front of me. But when you're thinking about, say, Wraparound to Fidelity, obviously the focus is also on education. And when we're talking in BVI about community support, you're talking about from day one choosing that educational, next step for that child. Mm-hmm. And as we know, many of our children with behavioral and emotional challenges, have had really poor experiences in schools. And so what we're really encouraging when we talk about education with residential programs is to individualize it. So there's a program, for instance, that's a smaller program. It only has 8 beds. And when I was visiting them, it was girls only, and they had only 2 of the adolescents were in regular education, meaning like in regular school. Most of them had some special education needs. But, a couple of the girls were older, 16, 17, and they had such school phobia that they were doing, 2 of them were doing GEDs, a couple were actually working and going to community college. One had a private tutor. They're really trying to support the youth because actually education is more predictive of positive outcomes than even family. And there's so much research on how important family is, but really education and finishing high school is more predictive of long-term positive outcomes. And so that working with the family is absolutely important. And in the same way that we said what are things that can be done, we need to make sure that education departments are part of practice improvement. So I'll be honest, in Massachusetts, they did all of child welfare, which includes a lot of juvenile justice programs, and they included all of the behavioral health, licensed behavioral health residential, but they couldn't get education on board with that. And education, so is kind of coming to it slowly in Mass, I'm saying in one state. And so whoever brought that up, I think it was you, Jane, but maybe somebody else submitted it, it's absolutely imperative that you work with the education departments towards changing best practices and with those programs who are funded and licensed by education in supporting those programs too. So it's no different. And if you look at programs like DAMAR, which I mentioned, and many of the other programs that have really moved to a best practice arena, their direct care staff actually go and support the youth when they're in their home community school. They do work in the school, and of course the school loves them because then they support more than just that particular youth. And so it's such an important area. I don't know what else to say or a very specific piece to say, but I think you hit the nail on the head with that.
Yeah. Do you have any research on whether kids coming out of residential, going back to the schools in which they came from, or going to different schools when they came back? Because schools so often are one of the major reasons why a kid may go into residential.
Well, I think that, talking about family-driven, youth-guided, we're talking about youth voice and choice and really finding out from those youth what does he or she want. And one of the biggest complaints we get from youth who have been in residential is that they lost, momentum with their studies, that the residential programs do not help them keep up. And so there's so many areas that one can focus on with that in terms of ensuring that it's really individualized, and that, and then that if the youth wants to go back to that particular school, that they are able to keep up, and that's a really big issue for these youth. But the other piece is just, again, getting that youth voice and choice, and what is the best school for this youth? Maybe it isn't the school he or she was in. Maybe there's just too much, I don't like to use such a loose term, but bad blood there for him or her, or maybe there's too much bullying that went on, or, there's, my own son had emotional challenges, and I remember it was like hearing this teacher talk about him. It was like I wanted to slug her, and it was like I took him out of that class. He can't be in that environment. So really really working to see what's the best environment because, again, education is like even preempts family in terms of outcomes. So I think it's just another important area, and there's a number of kind of strategies that one can use in that area, but it's not, I don't know if data related to which school they go back to. I think it's data that what we want to look at is what can we put in place to ensure that that youth graduates from high school and successfully. And so that's the outcome data that when we're looking at long-term outcomes, that's one of the issues is educational outcomes and then looking at vocational outcomes too. Now, there's a number of people who are on the line, Jane, Barbara Huff, who's been involved in so many things, but lots of who have really done this work and know BBI works, Nikki Toker and Pam and others. Is there anything that Nancy or any of you who have been part of BBI or part of this kind of residential best practice, is there anything you have to add to this? And then, Barbara, I do see Barbara Huff and rural communities. You kind of have a question. There may not be family support ideas, but how to create partnership when that family is 6 hours away. That's a huge one. We do use that kind of Skype and Google chat, of course, and so I think that we have to rely on that kind of long-distance kind of support. And, even when you're putting in place for long-distance families or families who live in rural areas, we're able to, if you look at William Beardsley's work, who looks at family members who have a mental illness, like a mom or a dad, and they can create those support systems for the children in this case, and sometimes for the parents, but so that like even a 4-year-old child can know to push a certain number on the phone because mom's acting that way, and then the neighbor down the street will come get him or her. So I think it's the same type of thing as what's the creative way we can set up, and I think you know that as well as anybody, Barbara, but that we do have to set up the supports in these rural areas for these families and these youth. And then we find sometimes it's the rural areas families that are just nervous about taking these kids back because the kids have had so many challenges and there's not as many supports. And so it's a real issue, but one with creativity and with working with the family from the very beginning, you can begin to identify those same kinds of supports and creative strategies that people like, as I said, William Beardsley and their evidence-based work or working with families with mental illness has done. So it takes the family support organization really. In fact, that's something else we need, Jane, is we need how do you work with families in rural areas? I know Kelly is going to write that down for us. It's like for you all too.
Mm-hmm. And Barbara just wrote that budget cards, gas cards, and hotel visits are other ways to assist families to stay involved. And then Nancy Craig, ruralness is a challenge, but connecting one parent to another is the essence of family support. Amen to that.
One of the things also we want to say, Barbara, and thank you, that gas cards for sure. But again, we want to be careful about the hotel because we want the child and family to be on their grounds when they're meeting with each other and with the staff there. And what we find that it's really hard for residential to transform, and they want to get stuck again in doing everything on campus, and that's where that's not where the evidence is. That's not the work has to happen with the families in their homes and communities, and so we got to be very careful about that happening because that's kind of they can spend the night near us, so we can do the hotel, but we're really looking at the opposite in terms of trying to get the money to get the staff to stay at a hotel close to the family.
Good point. Yeah.
I love Nancy. I love what she said. Rural, connecting parent to parent.
Yeah.
Absolutely.
And doesn't cost a penny. Yeah. Very good. This has been an incredibly informative and rich discussion presentation. I can see that we haven't lost anybody in the last hour and 20 minutes. I think that speaks to the importance of the message that you've given to all of us, and it's really a challenge. I love the term that family support in every residential program in the country. I think that is a challenge family organizations, family leaders can willingly take on and achieve. Can you tell us approximately how many residential programs there are in the country so we know what challenge we have ahead of us?
No, I wish I did know that. Callie, let's write that down. No, a lot. There's a whole lot of them. I know that.
A lot.
And many of them are not only not have heard about transformation and best practices, but they're still really, not because they're bad people. Again, there's some of the residential has some of the best people working ever, and they care about the kids, but they haven't yet learned that they're supposed to care about the families equally. And so that's something we'll put in our next book is the numbers we need. But no, you all know your geographical areas, and you can get that by state, you can get that by region, and know that just like, and I think that, Nancy, isn't it true, Nancy Craig, that every residential in New York is now connected in some way to a family support organization? Yes, she just,
She says yes.
She also said everybody her that she'll help you, everybody.
Okay. And a question, is the book listed on the documents and resource? I imagine.
Yes, it is listed, I believe, the resources.
Okay.
And my email is on here too if anybody needs anything else, so related to.
And you can get it through Amazon, or I downloaded it onto my iPad. You can get it in either form. Probably the hard copy is good if you want to pass it around to staff or even share it with families who may be coming in the door asking about residential treatment for their children. Or if you're going to connect with the residential treatment provider, give them a copy when you go in the door. Let them read about the values and best practices for residential treatment. So family leaders are change agents. This is something that we can do for our kids. I guess if we don't know how many residential programs there are, we don't know how many kids are in residential. But I loved many of the comments that you made about not just family support in every residential treatment, but every kid in their home for the holidays. We're not building traditions in residential programs. We're building traditions in children's homes. And I have to say, on a personal note, I always felt that I saw a difference in my daughter when she came home and slept in her own bed, in her own room, rather than in, a dorm or even a shared room in the residential program she was in. And Nancy says, if change is to happen, it will come from family support. We should reach out to the centers and let them know we're there to help them. Agreed. So this is just a beginning. This is not it's the end of this learning community call. It's the beginning of a much larger initiative where we as family leaders that haven't been involved, because I know many have, and a shout out to all of them on this call, and a heartfelt thanks to all the work you've done to this point. And Fredla is happy to join in this movement. And so let us know if you want to help in developing this tip sheet, potentially other resources, although BBI has an incredible number of resources for families as well on their website. You must go visit it, must get their book. And I just, so the copy of the PowerPoint as well as the research document are available right now. You can see them if you're at your computer, and they can be downloaded. The university is going to leave this open after this call for about 5 minutes for anybody who still needs to do that. If you are not at your computer, they will be available, and we will get them out through Fredla, and also they'll be on available on the Institute and we'll get that information to you as well. Anybody from the Institute know how long before the recording? It's usually about a week, I think, when the recording is available, but the slides are available right now. So, Beth, thank you from the bottom of our
heart. Thank you, and just best wishes to every family support person out there. I mean, just like Nancy said, you are the ones that can really help us to move to the best practice arena. And just thank you for offering to, spend your time with BBI. Just big appreciation to everybody out there.
Well, heartfelt thanks to you and everyone at BBI and the families who have been working in this area for so long, for all the children and families who have been, are, and perhaps will be in residential care. The work you do is invaluable. I just wanted to close with a few reminders that FREDLA is participating in Giving Tuesday on November 29th. So look for emails, posts on Facebook, and tweets to support the work FREDLA is doing. Giving Tuesday follows on Black Friday, Small Business Saturday, and Cyber Monday, and it's a national online campaign to support organizations you care about. We are delighted again to announce that we have a matching gift. This year the matching gift is $2,000, so anything you give, large or small, will be doubled up to $2,000. Last year we exceeded our goal and hope to do so again. So FREDLA is here to support and strengthen family leaders and family-run organizations. So we hope you will support us with a donation. All gifts, regardless of the amount, are appreciated. There will not be a learning community call in December. Instead, our next call will be on January 19th. That date was moved, so if you might have put it on your calendar for the 27th, it's actually changed to January 19th at 3 p.m. with Dr. Carmela Di Candida, and the topic is trauma and resiliency. I participated on a webinar with Dr. Candida last year and thought her explanation of how resiliency is learned was one of the best I had ever heard, and I invited her to be on one of our calls, and I'm delighted she accepted it. You won't want to miss this learning community and start your 2017 off on a great note. Lastly, and most importantly, we wish everyone a wonderful Thanksgiving. This is a great time of turmoil, and I have personally decided the way I'm dealing with it is to spend more time with the ones I love. That is what I wish for each of you as the Thanksgiving holiday approaches. Thank you again to Beth Caldwell, to all the family leaders out there, and to our tech friends at the University of Maryland who work all the technology miracles for us each month. Thank you again, and do have a happy Thanksgiving. We'll be talking to you in 2017. Thanks so much, everybody. Bye-bye.